We intended this session to be a little potpourri of a lot of different things, and it's my pleasure to invite Dr. Ashwin Reddy, who is from Moorfields Eye Hospital and a recognized retinoblastoma expert all over the world. And thank you, Dr. Ashwin, for agreeing to give this talk at such a short notice. And I would invite you to talk on advances in the retinoblastoma. Thank you.
Thank you very much for the invitation to speak. I'd particularly like to thank Dr. Agakar and AIOS for this great meeting that you've organized. I'm a pediatric ophthalmologist who treats retinoblastoma, and all the talks are relevant to what I do in my general practice. And I'm sure the audience will take on board a lot of the messages that have come through. Really enjoyed them. It was the morning here. It's a cold morning in London. So the cold morning I've had so far. So I'm going to talk about advancing retinoblastoma, but from the view of a pediatric ophthalmologist, and we've got pediatric ophthalmologists on the panel and listening here. And what are we interested in as pediatric ophthalmologists? We're interested in vision. So I'm going to emphasize the visual aspect in retinoblastoma here. And this is just a picture of a patient with retinoblastoma, fluorescein angiogram. We've just termed this Medusa-like a fluorescein angiogram with retinoblastoma. It's quite striking. So I'm going to be talking about visual loss, where kids with a macular tumor, what area of the retina they're looking at, and iatrogenic visual loss, where we're causing the visual loss with the new treatments. So visual impairment in retinoblastoma. So as you all know, we want to save these kids' lives. And if we can save the eyes, it's even better. But we need to consider the visual impairment and consider the visual outcomes, because they'll have that for the rest of their lives. So this is from London. And in the 1990s, of patients presenting to us, to our unit, 80% had a nucleation at presentation. Then we did a study recently between 2006 to 2010, and 60% were getting enucleations. And now it's between 30 and 40%. So with the advances, we are reducing our enucleation rate, yet keeping our survival rate high. And our survival rate in the UK and in London is around 98%. And obviously we get patients coming in earlier because we have a nationalized health service. But it's just to emphasize that enucleation rates are going down. So bilateral retinoblastoma and vision. A lot of the studies on vision in retinoblastoma is just looking at one eye at a time. And so in these studies with bilateral retinoblastoma, they found 50 to 60% getting 6/12 vision or better from the UK and the US in the 80s and 90s. And obviously, if you've got a macular tumor, you're likely to have poor vision. So we looked back, this is nearly 10 years ago, at our patients with bilateral retinoblastoma, and they are having the treatments that we're still giving now, systemic chemotherapy, intraarterial chemotherapy, intravitreal chemotherapy, and enucleations. And we wanted to know how many of them had visual impairment, as in bilateral visual loss. So there was a strong association, as before, with macular and poor visual acuity, with 92% of the eyes with poor vision having the foveola involved. However, sometimes you get surprised with macular tumors. And so this is a child with this tumor and yet 6/19 vision on Ks. And here's another child with a macular tumor and 6/12 on Ks. So sometimes you'll be surprised at what vision you get. And we obviously advocate amblyopia therapy for these kids, even though they may have macular tumors. We had 40% having enucleations, monocular enucleation, and 2 kids had bilateral enucleations. It's about 10 years ago. So with visual impairment, we had 20% sight impaired and 9% severely sight impaired. So we were certifying these kids and getting them early support. So as you all know, as pediatric ophthalmologists, if you have a young child with poor vision, their motor function will be affected because they can't see if they're trying to, say, grab their big toe and stick it in their mouth. So getting them to the support as early as possible is really important to improve their motor rehabilitation as well. And if we looked at the better seeing eye, it correlates with the international retinoblastoma classification, which some of you may know. It goes from A to E, E often enucleated, A is the smallest tumor. And if we look at visual impairment and legal blindness, the more advanced disease have these conditions associated with it. I think the take-home message from this bit of the talk is that over 70% did not require certification. So bilateral retinoblastoma needn't be a depressing diagnosis. They can do well. And you do not have to wait until providing support. Provide support as early as possible for rehabilitation. And if you're interested in this paper, this was published in Ocular Oncology Pathology in 2019. Now, having talked about bilateral retinoblastoma, I just want to mention a little bit about enucleation. So we're often in a battle with our oncologists about, well, shall we salvage the eye or shall we not salvage the eye? Removing the eye has issues. It results, this is monocular visual loss, so the other eye sees well, difficulties with motor processing and motor skills. 40% of children aged 3 years or younger who had an eye enucleated had to be referred to early intervention clinics for visual motor coordination deficits. And of course, there's the psychosocial aspects as well. The concern within the family, the worry of whether they're going to get married, if they're going to have kids, all this sort of aspect. So we are really trying to move away from enucleations as much as we can, if it is safe to do so. When it's not safe to do so, we have a child-friendly approach, and we have a more multidisciplinary approach that is the more recent advances, and lots of units have this now, where we try and get the whole team on board and try and help the parents and the child. So this is Dino, our dinosaur, and Dino has an eye that comes out. So we're trying to explain this to the kids and also to the parents as counselling before the enucleation. Now I want to talk a little bit about macular tumour. So which part of the retina, which is called the preferred retinal locus, does a child with a macular tumour use? So this hasn't been done for retinoblastoma, and we've done this. We used a microperimeter. We had to try and find the child who was able to do this. We had 5 children, only 1 child was able to complete the test. And this child had to have one eye enucleated, and we tried to salvage the other eye, which we managed to do, using chemotherapy, in those days, external beam as well. So this is our child with a macular tumour, and you can see all the damage in the macular region, who has 6/120 vision with eccentric fixation, logMAR 1.3. But which area is this child looking at? And we can only find that with microperimetry. So you can have a look at this now, and it's actually B, right at the top here, a bit like Best disease and other kids. If you deal with kids with macular genetic disorders, they'll be using the top end as well to look down. And this is a bivariate contour ellipse area, and usually it should be very tight where the cones are, but here you can see it's a much larger region. That's why the vision's poor. And this is the first patient to ever have microperimetry, so we can see exactly where they're looking at. Why is that important? Because we hope to get treatments to try and rehabilitate these kids and get them better vision. And that might include biofeedback or rapid serial visual potential to concentrate fixation. And we looked at the retina in these regions, and we found that the retina is healthy, but in the other regions, they're healthy as well. And this was published in APSPOS a couple of years ago, if you're interested. And finally, a new modern treatment we've been using for the last 12 years, intraarterial chemotherapy. And that involves, instead of giving systemic chemotherapy, which affects the whole body, you're giving the chemotherapy directly to the ophthalmic artery here. And it's great. Yeah, you could avoid enucleations, you may avoid relapses, and you might have less examination under anesthesia. But visual loss can occur through choroidal ischemia. So this is a very good paper from Chen et al. From Guangzhou. And you can see here, if you give intraarterial chemotherapy first line, 68% salvage the eye. These are for advanced disease retinoblastoma. If you use intravitreal chemotherapy plus intraarterial chemotherapy, it's about 62%. So in first-line intraarterial chemotherapy has a role, and we're moving more and more towards it now. But we found back in 2013 that you get visual loss with it. And that's a concern. And these are patients who had previously healthy foveas. And what we found, and there's been several studies in this area, is that if you, the position of the catheter is important and the dose of the drug is important. So if you reduce the dose and change the position, you can avoid the choroidal ischemia that's associated with visual loss. And this paper just shows when we reduce the reduce the dose, giving the chemotherapy in exactly the same place, we reduced our ischemia rate. So this is a whistle-stop tour really about retinoblastoma and vision. And if you're interested in this, we've got a paper in Eye, which is a review article of all the advanced treatments and vision with that. And this is just our team. We've got a big team with psychologists, place specialists, oncologists, and that's really important in the care for kids with retinoblastoma, and that's an important advance for management. Thank you for your interest.